Okay, well, good morning, everybody. It's really great to be with you all here. Thank you for making it out. Thank you to the online audience. I'm told we have a little over 100 people online, so thanks to those who have also joined. Um, our conversation today centers around emerging frontiers and new innovations in HIV care and treatment, and boy, are there many. And I know our panelists are going to get into it now. One of the things we wanted to highlight as well is that the HIV response is far from over. Globally, there are still 1.3 million new HIV infections in 2022. And here in the United States, only 65% of people who have been diagnosed with HIV are virally suppressed. And that's a number that's far below many other countries. But yet, there's much reason for hope and optimism. A promising pipeline of new drugs and innovations are on the horizon, both for treatment and for prevention. We'll hear a little bit about that today from our panelists. And there's also excitement and hype around digital technologies, in particular around AI-powered service delivery that is helping healthcare workers in remote settings diagnose and find patients, as well as mobile platforms where you could use your cell phone to get PrEP anywhere in the world. And so these are innovative technologies that are here and I think will help the HIV response. And these are the kinds of conversations we're going to be talking about today. So we've got a lot to unpack, and we've got a distinguished panel here to help us do that. Let me introduce them, and then we'll get right into it. We'll have about 45 minutes, and then encourage you all to ask questions, both online and those in the room as well. So first, I have Dr. Chris Beyrer, who's the Gary Hawk Distinguished Professor in Global Health and directs the Duke Global Health Institute. Chris, welcome. Dr. Mark McLennan, the director of the Duke Margolis Institute for Health Policy. Mark, thanks for having us here today in your space. Dr. Emily Kainne Dokubo, the deputy U.S. coordinator for PEPFAR. Ilda Kuleba is the director of Africa programs for mothers. The mothers here all the way from South Africa. Thanks, Ilda, for being here. And last but never least, Jen Cates, Dr. Jen Cates, Senior Vice President and Director of Global Health Policy at the Kaiser Family Foundation, also a member of the Global Fund Board, which I'll want to bring into the conversation as well. So give them a round of applause. Chris, if it's okay, I want to start with you. Tell us about where we are in the global HIV response. How are we doing with regards to the 2030 targets? And where do we need to be?
Well, good morning, everyone, and thank you all for being here, and thanks to Gerard for organizing this, and Krishna, Dayakumar, and Jihik, including us in this program. It's really wonderful to be with you at this really very important moment. And I would say that, in the 40 plus years now of the HIV/AIDS pandemic and the HIV/AIDS response, there haven't been many times like this one. We really are at a crux point, you might say, and that is because of the innovations you're going to hear about. We are in a period of really extraordinary scientific clinical innovation, and also, as Gerard mentioned, innovations in delivery and new data tools and new health system innovations that really hold extraordinary promise. But that's not the whole picture. The other side of this coin, unfortunately, is that we have really spent the last 20 years or so, the PEPFAR era, heavily investing in trying to provide antiviral therapy for the majority of people living with HIV. We still have a long way to go on those targets. But I think the concept that that would lead across populations and across risk groups to declines in new infections has panned out to some degree, but not anywhere near quickly enough for us to get control of HIV. And early on, it was said, we can't treat our way out of this problem. And that has turned out to be true in many ways. We absolutely have to do better with preventing new infections. And Gerard alluded to this is a UNAIDS, most recent UNAIDS estimate of 1.3 million a year. There's a pretty wide confidence interval around that estimate. Could be higher, could be lower. And those data, as we all know, don't include some very problematic countries like Russia that has a huge epidemic and where the data are unreliable. So when I look at that estimate, I always put a big asterisk there. I call it the Russian asterisk. And it's, we could be probably 100,000 infections under what the actual estimate is. We also, for years, have been seeing that there were two regions globally where the epidemic was still in expansion. In other words, where rates of new infection are still going up. And that has been Eastern Europe and Central Asia, principally driven by Russia and Ukraine, and then the Middle East and North Africa, from a relatively low baseline, but nevertheless expanding. Now, for the last 3 years, South America, Latin America, has been in expansion mode, and we have had steady increases for the last 3 years, and that is really very troubling. Those are mostly now middle-income countries, and they have been caught, hopefully we'll get into this in some detail, in a challenging area where access to prevention, like pre-exposure prophylaxis, oral PrEP, in many countries, has been really better in the PEPFAR-focused countries and really been better in low-income countries. But the middle-income countries have really been squeezed. They're not poor enough to meet a lot of the access program levels, and they're on their own challenged to be able to provide these services. So that is a real challenge, and it is being reflected in the US epidemic. So CDC, most recent data in the US, for the first time, new infections in Latinx Americans have exceeded African Americans. And that is almost entirely due to men who have sex with men. And it is really, at this point, one of the hottest outbreaks that we have. And it's really very striking because if you look at where oral PrEP, which is what our earlier innovation was, daily oral or intermittent oral for gay and bisexual men, it really has been very effective, and it really, with treatment, can actually get control of HIV outbreaks, but only outbreaks in men who have sex with men. So we have very good data from Australia that PrEP now, with treatment at population levels, is bringing that epidemic to an end. The UK, the Netherlands, and white gay men in the United States, doing great. Over 85% of white gay men with a PrEP indication are on PrEP, and our epidemic has been coming down steadily for the last 6 or 7 years. It's very heartening. It's down by 2/3. It's flat for African American gay men, and it's rising in Latinos, just like the source countries from which they're from. So that is a challenge that is going to require going beyond oral PrEP, going into new delivery systems, delivering the innovations you'll hear about, including, of course, the most exciting recent ones, which are long-acting injectable antivirals for treatment and prevention. That's the big news. I'll just say in my last moment that I'm on my way, as several people here are, to the next HIV Research for Prevention meeting. That's the biomedical prevention meeting. We're holding it in Lima, Peru, because that region really is in need of advancing prevention. And we're going to have both Purpose 1 and Purpose 2 trial data presented really for the first time in full. And those are the trials in cisgender women in sub-Saharan Africa. What was the efficacy of lenacapavir in cisgender women? 100%. That's very rare in medicine. I can tell you. I've been at this a long time. And in men who have sex with men, the second trial, it was a little over 99%. That's about as good as it gets. So we are on the cusp of something very, very exciting, and we also are facing some deep challenges. And that's why I say this is a crux moment in the response.
Thanks, Chris. On the cusp of a lot of excitement and deep challenges, I think is a really nice summary. You mentioned PEPFAR a couple of times, so let me bring in Kainne. Kainne, PEPFAR is at the center of the global HIV response for over 2 decades now, and its progress is well celebrated and recognized here in Washington and around the world. What are some of the challenges you're facing now, not only to sustain the gains that Chris alluded to, but also accelerate some of the gains? Tell us about where PEPFAR is going in the next 5 years.
Thanks, Gerard, and good morning all. It really is a pleasure to be here, and to those who are online as well. It really, as you noted, PEPFAR over the past 21 years since it was established has made a significant impact on the global HIV response. In over 55 countries that PEPFAR supports, a lot of work has been done to response to HIV, where we've seen over 25 million lives saved through PEPFAR support. Over 20 million people are currently on life-saving antiretroviral treatments. Over 5.5 million babies have been born free of HIV, even though their mothers had HIV. And new infections have been prevented, millions. But we're at a point where we're no longer in the emergency phase of the response. Again, when PEPFAR was established and has enjoyed bipartisan support over many administrations, we've really focused on providing that essential support to respond to HIV globally, where it was devastating for many countries, impacted their economies, impacted their health systems. And through all the progress that's been made, we're now at a point where we need to ensure that there's continued support to sustain the gains that we've made, and also accelerate progress to close gaps where we still see them. Even though we've made a lot of progress, as Chris mentioned, we're still seeing millions of new infections. We're still unfortunately seeing children born with HIV. We're still seeing significant equity gaps and disparities, especially among key populations, priority populations, for example, adolescent girls and young women, where in some places, their risk for HIV acquisition is up to 6 times higher than their male peers. And so how do we ensure that these vulnerabilities are addressed and that we're all working to close those gaps and achieve the 395s? That's among persons living with HIV, at least 95% of those are diagnosed, of which 95% should be on life-saving treatments, and 95% of those on treatments should be virally suppressed for their own health and for public health prevention and for preventing further onward transmission. So there's still a lot of work that we need to do. And that's why it's incumbent on us to keep that focus and continue to remind people, because unfortunately, in some ways, we've been victims of our own success, where because of a lot of the progress that we've made, many people do not see HIV as a threat, but it continues to pose a threat to our national and global security, economic systems. And so we need to continue to prioritize and ensure that funding is available. And we're thankful that PEPFAR has, again, enjoyed bipartisan support over the past 21 years. And we hope that we can continue to do so with an upcoming 5-year clean reauthorization. We also at PEPFAR are supporting partner governments to ensure sustainability of the response, working in close partnership with partners like UNAIDS, Global Fund, and other multilateral stakeholders working closely with communities to ensure that sustainability plans are being developed. Again, we're no longer in an emergency response, but we're in an inflection point where we need to ensure that all the gains we've made are sustained. So how can we support partner governments to really take ownership and leadership of the response efforts, including policies that support delivery of services, protections for key populations in an environment where we're seeing a lot of punitive legislation that make it harder for us to reach those most at risk? How can we ensure that those vulnerabilities are being addressed? How can we ensure that we are prioritizing children where we continue to see those key gaps? Because performance, diagnosis, treatments, viral suppression outcomes are much lower among children in our pediatric populations. So there's still a lot of work for us to do.
Thanks, Kainne. There's a lot there that is to be celebrated, and also what I'm hearing is that there's a continued need for political will, both here from our government, but also governments around the world to sustain and accelerate the gains and continue the progress, including you mentioned around international collaboration as well. You mentioned UNAIDS and other partners, Global Fund. So I want to come back to that. PEPFAR's reauthorization expires March 2025. And I know that's a big topic for priority for next year. Ilda, I want to bring you into this conversation. You're a partner of PEPFAR's on the ground. Mothers to Mothers has been at the forefront of delivering the kinds of successes that Kainne is describing for the PEPFAR program for mothers, for adolescent girls and young women as well. What is it like in terms of scaling up these innovations that you've been at the forefront of, especially community-led interventions? And what have you seen as potential for the future?
Sure, thank you. And good morning, everyone. So Mothers to Mothers, an African organization, and we were born to end the transmission mother to child. That's what we were that was our initial goal. Today, we tackle integrated healthcare, still looking at HIV, but also looking at what other health issues our communities are facing. And the approach that we took at the time, 23 years to this day, was looking at training, employing, and supporting local women living with HIV. And it's a model that's peer-led, but it's grounded on trust. It's grounded on lived experience. It was one mother speaking to another about what it's like to live with HIV, what it's like to be stigmatized, what it's like to have a child or being anxious that that child may be born with HIV. And what started at a single site in Cape Town, South Africa, we've expanded in 11 countries. We've employed 12,000 women across these 11 countries in Africa. We've reached 16 million people and have kept alive 3 million women who are at risk and children. And I agree, we're far from reaching and ending HIV, but I think the work that we have done in actually listening to our communities and to making sure that we are making adjustments to scale and to respond to what the communities need, we've seen a lot of great results. When it comes to retention and care, a lot of what we've done, we see that among the cohort of M2M, we're looking at 97% retention at 12 months. We're looking at 95% at 18 months, 92 at 24. So we're doing something right. There's really a lot to be hopeful for, because I think it's about these community-led interventions are truly needed, and we have to listen to what are our communities telling us. And for us as Mothers to Mothers, we are so incredibly proud that with our partners, with governments, among our cohort in the last 10 years, we've seen virtual elimination. And just last year, among our cohort, we had 0 transmission. So that means 0 children that were followed by mentor mothers or our peer mentors. We didn't see one single and in order for this, we really had to evolve. When we first started, our interventions were only based at the facilities. We had our mentors, a health worker identify a woman, whether she was pregnant or breastfeeding, and linking her to this mentor. And we saw that in order for us to drive demand for services, and in order for us to identify people in the communities, we needed to have a community mentor. We needed to be able to have someone who can go into the community and to build that trust and to really have that linkage back to the health facility that a lot of times people regard as very hostile and not able to meet them where they are. And we also complemented a lot of this with digital services. Our community health workers have smartphones that allow them to capture information, allow them to identify which population is at a higher risk, which household is at a higher risk. And also to go back to the community component, it wasn't just about that mother and child. It became about a household intervention. Who was at that household? If we had an adolescent, how do we reach that adolescent? How do we make sure that the information is tailored to the household? And how do we make sure that we're going back with this information so that we can best serve our population? During COVID-19, we had to look at ways in which we can be as creative as possible, not to lose the gains, and making sure that at a point where everyone was scared of the health facility, everyone was scared of face-to-face engagement, we created a peer via phone, making structured calls where our communities were still able to speak to their mentors. We also had developed the virtual mentor mother WhatsApp chatbot that allowed and allows, and it's in different languages, but allows our clients to be able to access information at their own time, wherever they are, without necessarily have to get to the health facility. So I think that with the great support of PEPFAR and various other donors, I think there's so much to be said about the need to continue to advocate for community-led interventions and continue to advocate for results that come from the ground up so that we can best respond to the epidemic. Thank you.
Thanks so much, Ilda. Yeah, not only the results, but the innovation that's also coming from the ground up, as you described during the COVID pandemic, but also beyond. Well, thank you very much for sharing those perspectives. So we got an epi lesson from Chris about where we are in the state of the response. We've heard from the state of PEPFAR currently and the progress that's being made, and then Ilda's firsthand perspectives from the field. And now we're in Washington, so we need a bit of a reality check about the fiscal space, the political space. So I'm going to bring in our two Washington experts here. Jen, let me start with you. We heard last week at the UN General Assembly a warning from the United Nations HIV/AIDS program, UNAIDS, about how rising external debt and the limited fiscal space is forcing countries to prioritize debt repayment over healthcare for their own populations. The Kaiser Family Foundation, and in particular you, Jen, have tracked HIV funding and global health funding broadly. Tell us where we are. What are the recent trends, and what policy changes do we need to think about as we're considering these financing trends?
Well, thanks so much, Gerard, and thanks to Duke for asking me to be part of this. And I know, Gerard, you've asked me to come maybe be the skunk at the party, so I'm sorry for that. But
I mean, that's why he was saving me for last.
yeah, well, we can tag team. But there's a real, as you mentioned, countries themselves, so countries that are recipients of funding from PEPFAR or the Global Fund, who are, the partner countries that are facing HIV epidemics, have always been a source of some level of financing as well. But the environment in which they operate is much more constrained than we've seen in very long time, because of COVID, because of debt, because of all these factors. So the ability of countries, even if they have the political will to manifest new resources, is pretty limited. And that brings up, this tension I think we're in with, we have all these innovations, and including the new innovations with long-acting injectable PrEP, but we have a very fiscally constrained environment. My organization, along with UNAIDS, has been tracking donor government funding for HIV. We've been doing this for almost 2 decades. And I'm sorry to say that it's not in a good place. A few trends from our most recent report that came out in July: donor government funding, so that's the funding from the United States and other donor governments, actually went down over the last year. But there's fluctuations from year to year. But more importantly, the longer trend is that the current level of donor government funding for HIV, which is a huge part of the response, is back at 2008 levels. That really means that what we're able to do is very much affected by a lack of increase and inflation and all of these things. So it's not keeping pace. That's one. Two, within that, the US has always been the largest donor government, but that has increased. The US is increasingly shouldering the burden here. Why is that? Because when we look across the other donor governments, those in Europe and around the world, they are decreasing their support for HIV. HIV is not the primary issue that they are focusing on now, for sometimes for very other reasons that make sense in their context. But it is the case that even though many donor governments are giving more to the Global Fund, and we can talk more about that, they're decreasing overall how much they're giving to HIV, and that's putting even more burden on the United States. So it just creates, I think, a pretty challenging environment and some risks as to how to respond and be prepared for these innovations, but also what does it mean for the US? What does it mean for the Global Fund? the Global Fund itself, for those who don't know, is a multilateral institution, an independent public-private partnership that exists to mobilize resources for HIV, TB, and malaria. It is about to launch or starting to launch into a new replenishment phase where it's going to be asking those same donor governments to provide additional resources. So it's, this is I think a challenging time. I don't necessarily have easy answers for it. One last thing, UNAIDS tracks more broadly funding for HIV, not just from donor governments, but from foundations, from partner countries and the private sector. And that trend is also going down. The gap is getting bigger. So whereas in the first decade of PEPFAR and the Global Fund, we saw this rise in financing, now we're seeing it's just not keeping pace. So lots of challenges out there.
Jen, I want to come back to you on the Global Fund in particular and some of the innovative financing in our next round of questions. But I want to bring in Mark, who's no stranger to operating in difficult environments, in particular being at the forefront of U.S. healthcare leadership. Mark, you've witnessed a lot of transformations in our own healthcare system in the United States. What lessons can you provide for the global response, not only for us to continue to innovate and incorporate these innovations, but also in the process generate more political goodwill towards what we're trying to do?
Yeah, well, first of all, this is a great panel, and I especially want to thank Jen for providing all the bad news before getting to me, so I can kind of move on beyond that. I want to thank Kainne for reminding me of how old I am. So that 21 years ago, when PEPFAR was starting, I had the privilege of working first in the White House with people whose heart and souls were going full time into getting PEPFAR off the ground. Gary Edson, John Bridgeland, the whole team, especially President George W. Bush, and then had the privilege of going to FDA as PEPFAR was getting implemented to get regulatory issues resolved globally. So yeah, I had my focus on the U.S. health policy issues at the time. But these affect the U.S., these affect the world, especially infectious diseases. We're all in this together, and that's been very clear in what we were trying to do in the administration then, getting PEPFAR off the ground, and it's been clear since then in responding to everything from global crises like COVID to I could go on down the list. So I always think about three things with trying to find a path forward, especially a bipartisan path forward on political issues. The financial environment is one of them. How do you get traction? And that is unquestionably much harder. Those trends are not happening just for random reasons by accident. In the last 2 decades, what's happened? Well, we've seen tremendous medical progress and overall significant improvements in longevity and health in most countries. U.S. has had a downward turn for the last few years. It's maybe starting to reverse. Our opioid deaths are finally coming down and some other good trends. But along with that, we've got a much better medical capability in the U.S. and around the world, and people are living longer, and that means more government spending going because of demographics and because of healthcare going domestically into those programs. Second big thing, not surprise anyone, is that it is a tough global security environment out there these days, with countries bolstering their own supply chains, their own capabilities for supplying their own citizens and allies and so forth. And the U.S. is asking other countries at a very high priority level for additional contributions globally, but that's primarily around national security right now, upping the contributions for NATO, for dealing with war in the Middle East, for the situation in China and Taiwan, and those issues don't seem like they're going away anytime soon. So that's the reality there. The second thing that drives health policy is the technology opportunities. And it is just so, I just have to say, and I'm dating myself, it's so amazingly different in the HIV world today. When I was practicing in the 1990s, my patients were dying. That was it. And I got to see them over the course of the decade go from, getting to supportive care in hospitals to walking out of the hospital to never, hardly seeing me, and now living a full lifetime. That's what led to the motivation for PEPFAR. It's like, that was happening in the United States, and there were like almost no drugs making it, antiretrovirals making it to sub-Saharan Africa and many other parts of the world. And that's just like intolerable. It's great to see the political motivation around that. That has changed now. We not only have great antiretrovirals, but as Chris and others were pointing out, we have amazing PrEP treatments. So some very impressive announcements this week and recently, 99%, 100%. Suppose you've got a trial that was large enough, you could probably get it below 100%, but that is amazing for prevention and treatments you might only need like twice a year. And also seeing progress this week. I know you were focused globally, but CMS announced in the US there's going to be free coverage of PrEP treatments through Medicare and Medicaid programs. And we don't have everybody insured in the United States, but a huge progress on the affordability of these medications. And I know some of those steps are kind of in process with licensing in the rest of the world. And but amazing progress, I think, on making drugs available, even though we're not there yet. I think the other big change has been delivery systems. So 20 years ago plus, we didn't have anything like what Ilda was describing, not even in Cape Town and not even in the United States. We had primary care systems that were sort of fee-for-service based, hadn't really figured out, hey, if we got people involved in the community who are actually trusted by local community members, it's much easier to reach them. We have amazing technology to support this now, not just for the US, but elsewhere. And yet the delivery systems, like you've described, I think are still the exception, not the rule, not only in sub-Saharan Africa, but in the United States as well. So there's some real parallel efforts. So, given limited resources, how do we make healthcare delivery work more efficiently? How do we go out and find and engage the people who can most benefit from these treatments? Because I'll tell you, even free drugs is not enough, as we've seen, to eliminate, Hep C, HIV, other problems where we have cures. We just don't have aligned delivery systems that ought to be able to do this. And I think that brings me to the last point, which is it's a different world than it was back when PEPFAR was created. And I think it's going to be, I'll just be blunt, and again, you gave them the bad news. It is going to be hard to get reauthorization of full level for this program. It is also going to be hard to maintain the same kind of motivation that was present 20 years ago for the reasons that I described. But I think it's easier to get motivation in a different direction, which is Ilda's. If you can make progress on primary care-based delivery systems that are community-based, that are super efficient and technology-enabled, the best HIV programs I know of, at least, are ones that aren't just looking at HIV by itself, but like you said, are engaging moms and people who are at risk. Got 2 more sessions today, one on HPV and cervical cancer, one on trust. Those all go together these days. That was not the case as clearly 20 years ago. So is there a way, recognizing that HIV donor funding capacity is going to be more limited, to recognize and just engage on these changes, like do some jujitsu here to make clear that this spending, even if it's at a lower level, could potentially be much more productive, because the world has changed. Some of it's in good ways, and I just hope we can embrace and build on successes like the ones that you've done. I think that could really engage on a bipartisan basis people in Congress, just like we were able to do 20 years ago.
Thanks so much, Mark. You did exactly what I hoped you did. You lifted our spirits, and then you also ended with a reality check that all of us face and need to overcome. So thank you very much. I also want to acknowledge your leadership when you were at FDA, setting up the tentative approval process for medications to be approved for the same medications that we were using in the United States to be able to be used around the world, while protecting IP in the here and allowing that innovation to flourish around the world. So thanks, Mark, for that and for being part of the conversation over the last 20 years. All right, so we're going to do one more quick round of questions, 2 minutes each. I want to unpack some of the themes we've heard, and then we'll go to the audience and see if there are any questions in the audience as well. Chris, Mark said that we don't have a cure, we don't have vaccines, but we have tremendous innovations. You've hinted at long-actings already. You're going to Peru this weekend, which is the R4P, the HIV science meeting. You've just come from Munich. Many of us were in the HIV scientific meeting in Munich. What excites you about research and where we're going? And in particular, what research is going to get us to those 2030 goals and those gaps that we're all highlighting have to be filled?
You know, if you go back to that period that Mark alluded to, and particularly the long period from the discovery of HIV until the development of antivirals, the fact is that there were very few antiviral drugs for any viral infection for treatment. Just wasn't a part of the pharmacopoeia. There were only two when I was a medical student, right? Acyclovir, right?
Yeah.
Lamivudine, that's it. And HIV led the way toward rational drug design, this whole explosion of small molecules. The Hep C cures, hepatitis C cures came out of HIV antiviral research. And I think that we're seeing that again. So the long-acting injectables, long-acting cabotegravir for treatment and prevention, and now, of course, lenacapavir, assuming that it is approved by the FDA and others, which is looking very promising, of course. These are, I think, going to be the future for many diseases. The long-acting injectables, implants are really here. They have been in some other disease systems. And hopefully, once again, HIV is going to lead the way into really a new era. I think what we're so excited about, the downside is something we have to acknowledge, which is that oral PrEP in particular just did not deliver what we were hoping, particularly for women and girls in sub-Saharan Africa. The uptake and PrEP starts were impressive, but adherence was a problem. Persistence over time turned out to be an enormous problem. And by the end of the first year, more than 80% of women and girls prescribed PrEP were not taking it. And to meaningfully change your lifetime acquisition probability, 6 months of PrEP doesn't mean anything. A year of PrEP probably doesn't mean very much. You really need to be on it through the period of risk. And that for women is mostly through reproductive life. So how are we going to do that? How is that going to change? I think the promise of long-acting injectables in particular, the thing that I find the most exciting, is that they now offer the promise of integration with hormonal contraception for women. So, you know, we might be in a place this time next year where you could say reasonably to a woman, here's your 3-month Depo-Provera hormonal contraception. Would you like HIV prevention at this visit? Okay. So, you know, you need 4 Depo-Provera injections a year. You need 2 lenacapavir injections a year. The synergy there is something I think that's enormously powerful. Destigmatizing, gets away from risk, no pills at home, family doesn't have to know, male partners don't have to know. And I see that as an area where we've been wanting to do this kind of integration, and there's no more important primary care intervention than family planning and contraception for women, right? It's so fundamental. So that to me is a unique opportunity.
Exciting, Chris. Thank you very much for sharing that. Let me come to PEPFAR. Oh, Kainne, we heard service delivery innovation, digital technology empowered innovations. We have a 5-minute warning, which I think is not true, but now it says 2-minute warning. Okay, so no, we've got another 10 minutes. But tell us from the leadership perspective of PEPFAR here at headquarters, how are you prepared for these innovations? How are you adapting programs? How are you providing guidance to countries to be able to incorporate these digital technologies, these innovations that are on the pipeline? I know PEPFAR is doing a lot, but we'd love to hear more about your priorities in this space.
Indeed. Part of the reasons that PEPFAR has been successful is really embracing innovation and focusing on client-centered care. How best can we provide services to those whom we serve in a way that they want to receive it and where they want to receive it? And so ensuring that it's very convenient for users increases that demand and uptake. And so some of the things that we've done across our treatments portfolio, app-based services that enable clients to be able to schedule appointments, schedule medication pickups, appointment reminders as well, and also feedback on the quality of services that you're providing. So engaging in that manner has really allowed us to be able to provide services and keep clients on care and providing those quality services. We also have computer-aided detection of TB, for example, which has facilitated the screening and diagnosis of clients with TB to improve their outcomes as they're linked to treatment. So these are just some examples of how we've embraced technology and innovation. We also, I mentioned the 395s earlier as a metric that we're working to achieve in the different countries that we support. There is still a number of people who are missed in countries that we're supporting who are undiagnosed, who are not on treatments. Either they're not linked to treatments or they've had interruptions in treatments and they're not virally suppressed. So we're also exploring how to use AI to help predict that so that we know who we need to prioritize. Looking at our program data, looking at different tools, how can we identify persons with HIV who as yet do not know their status so that we can focus our interventions to reach them? Who are those that are likely to have interruptions in treatment for various reasons? And how can we have added support, enhanced adherence counseling to support them? Who are those that are most likely to not be virally suppressed? And how can we provide those support services? So these are some of the things that we are working on and using just digital tools and technologies to help support that. And then coming back to prevention, PEPFAR is proud to have been to have helped to introduce long-acting injectables in many countries in Africa, which were the first outside of a study setting. Introduction of cabotegravir long-acting in some countries starting early this year, and we're also excited about the new results, as has been mentioned, with lenacapavir and the promise that it brings. So we're fully committed to getting those tools out. Again, scaling up treatments, ensuring that it gets to those where there are significant gaps, also scaling up prevention and embracing the new tools, which are now an additional tool in our tool combination prevention toolkit to ensure that we close those gaps, reduce new infections, and work toward our goal of ending AIDS as a public health threat by 2030.
Yes, thank you so much. And that innovation in cabotegravir introduction was also for Ukraine as well. So it was pretty widely, and most of the initiations, I forget the exact percentage of PrEP worldwide, come from PEPFAR support, right? And
Indeed. So PEPFAR has accounted for over 90% of PrEP,
90%.
pre-exposure prophylaxis scale up globally, which is quite significant.
So thanks for sharing. It's good to see the innovation that PEPFAR is providing to the field. Of course, with more financial need and political support to take these to scale. Ilda, I want to bring you into Mark's point about the charge that he gave for the future, which is operations like yours on the ground, and taking scale in terms of taking innovation to scale in terms of the way your service delivery is changing. Where do you see the next 5 years in terms of you're sitting in the country with the largest epidemic in the world, the most number of people on treatment around the world, and the biggest burden around the world. So what happens in South Africa impacts the entire world. Where do you see the next 5 years, and where do you see organizations like Mothers to Mothers playing a leadership role?
Thanks. I think we've started doing a lot of how do we use this model, not just for HIV, but to ensure that we increase the awareness around HPV, awareness around vaccination. So I think that we need to take a lot of the learnings that we've brought in the last 20 years to really hone in on where we see the gaps. I think it's important for us to, as Kainne said, I think the people-centered approach is key. And I think we really need to reframe the idea that there are hard to reach populations, but I think there's hard to reach services. Because I was a country director in Mozambique for 5 years. And one of the things that was very critical is that some of the populations who lived in rural areas had to walk over 40 minutes to get to a service delivery point. So how do we make sure that our models can become more centered around to make it easier for our populations to access care? And in some cases, we have seen some of these innovations through having groups where one person picks up medication for 4 or 5 people within their community, as long as they've shown to have HIV suppression. It's very important for us to keep listening in on what is needed within the community. I also think that there will be a shortage of healthcare workers in sub-Saharan Africa. So the push for community health workers, paid community health workers, is needed. And I think it's crucial if we truly want to see the tide change, because I think if we don't do that, we will probably be having this conversation again in 5 years. I mean, it's really important for that. And I think a theme that's gone on since yesterday is the need to have integrated care and not siloed care. We see that's important. When a woman goes into to a health facility and she's breastfeeding, she should be told about what are the family planning options she has for birth spacing. She should be, if she has an adolescent at home, she should be receiving information around HPV vaccines. I think that the role that an organization such as Mothers to Mothers is advocacy, one of them. We are at the forefront when it comes to paying and professionalizing community health workers, and we've seen and we have proven that it works. And in places where you have paid community health workers, you see results. And so I think that that's truly important. And to keep testing, how do we use the model, not just for HIV, but for other disease areas? So I think that I see our role really expanding and being a proof of concept when you're talking about integrated healthcare.
I like that look into the future. We saw how PEPFAR platforms were used for COVID vaccine delivery and also Ebola response in West Africa prior to that. So thank you for that look into the future, Ilda. Back to Washington, Jen, I want to ask you about what shifts have to happen to be able to address some of these challenges. I mean, you mentioned the Global Fund replenishment. Mark mentioned the NATO replenishment, which was not even on my radar. But there's so much more. We know Gavi and others are replenishing the pandemic fund, which was just created to raise money. I know, Jen, you're also a member of the Global Fund board. So if you can bring in some perspectives from the Global Fund, which is the Global Fund to fight HIV, TB, and malaria, a big partner of PEPFAR. What are they doing differently as it relates to co-financing? Is there something that we could learn from our bilateral programs? And how do we kind of solve some of these challenges that we're beginning to hear about as we go into a reauthorization period next year?
Thanks. Let me start with PEPFAR, because we've heard here that there's some tension and strain around support for PEPFAR. I mean, there's still a lot of support for PEPFAR, but really about the future of PEPFAR and what it should look like, and is there enough congressional support and excitement? And I think that's a question. So one point on that, the excitement and innovations that we've heard over here, both from the two of you, that Congress doesn't know about that. So part of this is that education hasn't happened yet to tell members that have been there for a while, but also newer members. Not only has this program for 20 years done all of these things, but look what we're on the cusp of. So that information is just not known. But also increasingly, whether there might be a lot of support for that, there's a lot of fiscal concerns about PEPFAR. PEPFAR is a $5 billion program a year, which in the global health world is a lot. So one of the things that I think PEPFAR is starting to consider and others are looking at, are there ways that PEPFAR can fiscally approach its future that are a little bit different, and it can borrow from the Global Fund. So the Global Fund has a couple of mechanisms that have been in place for a long time that PEPFAR hasn't really employed yet. And I'm just going to cite two of them, and they may be things that could help garner support and trust by Congress that PEPFAR is a steward of U.S. resources. One is co-financing. So this is the idea that countries that are recipients of support should also be required to put some money on the table. That's difficult. I already mentioned that it's difficult for a lot of countries now, but it really does signal that this is a co-investment. And that sends a lot of, I think that message is one that might help with congressional attention and support. The other thing that the Global Fund does is actually has transition plans and transition points at which once a country reaches a certain point in its economic development and its epidemic, they're no longer eligible for funding. That's not how US programs usually operate at all, but it may be time to rethink that. And so I know we're short on time. I'm just going to leave it there, but these are a couple of things that are being done in other contexts that may lend themselves to rethinking PEPFAR, but also the broader US development portfolio.
Thanks so much, Jen. You know, another area where I think Congress's attention can be piqued is around public-private partnerships. And Mark, I want to ask you about the role that the private sector can play in not only continuing to innovate, but also being part of the service delivery.
Yeah, I mean, private sector involvement it's happening everywhere around the world. Question is, can it happen in a way that is not adding to disparities and is actually contributing to exactly the kinds of evidence-based models we know work? And to build on Jen's points, and I'll be brief, but ways of engaging Congress. Number one, this is a shared commitment. This is not just US money with Americans disproportionately paying for stuff for the rest of the world that doesn't benefit them. This is a leveraged program. It's going to create global health security, because what we're talking about here is models like Ilda's, which not only help address the HIV problems, but also create a stronger foundation for countries to build out their own primary care systems effectively. And think about what does the future look like for this program? In 10 years from now, we ought to have community health worker based programs, AI and tech enabled everywhere on the planet that are much more effective at, you can't do family planning without trust. You can't do adherence to medications without ongoing engagement. And that ought to be out in the community with people. There's no excuse for not getting there. And this is a great way to lead globally to get there. That means bringing in some country responsibilities as they develop and as they build out their own capabilities. This program isn't going to last forever, at least in this way, and bringing shared commitments from other donors and donor nations. So that also creates a foundation for getting the private sector involved. The most effective private sector programs I've seen are ones where there's government oversight, like we do in our Medicare programs, increasingly in our Medicaid programs. Those are all federally overseen, but definitely privately delivered with a lot of private innovation in the care models. But there's an oversight and accountability for what the private investments and private contributions do.
Thanks so much, Mark. And I know we have private sector in the room, so let's turn it back to the room. We've heard a lot about the innovations, the implementation challenges, the fiscal and political challenges. We've got about 5 to 7 minutes, so I would invite the audience to participate if you have questions. I think we have enough time for maybe 2. I see one here, and then I see one over here.
Good morning. Thanks for this wonderful panel. My name is Chris Collins. I'm with Friends of the Global Fight. Ilda, what your program is doing is so wonderful, and thank you. And thank you for being here. I wanted to ask your perspective. You're talking about a program from the community, from the ground up, that's expanding to provide more services. And I just love to get any further perspectives you have. One of the big movements now is integration of HIV into health systems. And there's a lot of good there, and there's a lot of need to do that, of course. But would love to hear your perspectives from someone who's working in a community organization. What are the hurdles and the opportunities in integration? What do we need to watch out for? How do we think about making HIV integration into health systems work, knowing that a lot of that care is going to happen in health systems, not in community groups? Obviously, we need the community services for sure. We need to keep that investment. But I'd just love to get any perspectives you have on priorities in the integration agenda.
Let's take one more question, Lisa, and then we can wrap it up.
Thank you. Hi, my name is Tiff Jang. I'm a Master's of Public Policy student at Yale. And I kind of wanted to build off of the last question about the private sector, because I think from what I heard from the conversation, there was somewhat of an allusion to the Gilead news about them supporting the production of generics. And I guess reading the news actually made me feel that, the private sector has imposed some barriers to care as well. So I was curious if you could talk a little bit about what other sort of policies could be improved to relieve those barriers from the private sector side. Thank you.
You take the first one.
So thank you for your question. I think there are naturally a lot of challenges and hurdles that we need to take into account. One of them, health worker burden. I think that we're pushing for integrated care because it makes sense, but on the ground, we still do find a lot of the care is delivered in a siloed manner. I mean, you have health facilities that a woman goes into one door to get her ANC services, and then she has to leave and go and get tested at a different location. So we need to make sure that we're working with the governments into making sure that how do we bring in these innovations to the ground up at the health facility level? Are we training our nurses? Are we training our doctors? The health workers need to be they're just as important as the community health workers. In fact, if they're not on board, it makes it very hard for us to be successful at the community level. So I think that that's one main thing I feel like we need to take into account.
Kainne, do you want to come in on the integration piece before we wrap up?
Yeah, and I think it was mentioned earlier in how PEPFAR systems and platforms really have been used to provide services for other health conditions outside of HIV. And that's one of the things that we were intentional about, because HIV does not exist on its own, and we cannot continue to provide services in a siloed approach. At the start of the response, yes, when we needed to move fast. But what we've also seen is that, again, looking at a client-centered approach, there are so many other issues that need to also be addressed. And so when somebody comes in for their HIV care, they're screened for other comorbidities, and that's also treated. And PEPFAR services, through our health system strengthening efforts, we've trained over 300,000 healthcare workers who, when they go out and they're providing services, it's not just focused on HIV. Even the community health workers that Ilda mentioned, when they go out, if they're testing for HIV, they're also able to test for malaria. They're also able to counsel on cholera prevention, on WASH, water and sanitation and hygiene. So this is what we expect for the future of our health systems to ensure sustainability, is that integrated model, but also ensuring that we're not losing the focus or losing the gains that we've made in the HIV response. So this is essential. And Chris, to your question, this should be done at the health facility, but also at the community level. And so how do we ensure that we're bringing all of that to bear and really working to strengthen and ensure we have resilient health systems able to address multiple disease threats?
Large task. And Chris, on the issue of the Gilead licensing territory, what's
Yes.
in, what's out?
Let me just very briefly, though, say it's also important to say, you know, that the research infrastructure for HIV has also been leveraged for other innovations, and the most prominently, of course, for the COVID vaccine trials. So, but also, you know, we have three big networks that the U.S. has funded, the NIH has funded for HIV research: the Prevention Trial Network, the Vaccine Trial Network, and the AIDS Clinical Trial Group, ACTG. So ACTG did the trials for the COVID antivirals. The HPTN did the trials for the broadly neutralizing antibodies in COVID. And the HVTN became the co-VPN, which I worked on and mounted 5 efficacy trials with 30,000 volunteers in 6 months. And none of that could have happened without the HIV investment. So just to say, it really did deliver. I think the issue that you raise, indeed, one of the big announcements after we've had these 2 very successful trials of Gilead's new long-acting injectable twice-a-year injection, lenacapavir, has been the idea, and all of you who are innovators, Krishna's work has very much been about this, will appreciate that there has been a long timeline from scientific breakthrough innovation to actual delivery in the clinic to people or in the community, often decades or longer. And we are trying to shorten that in a major way. And Gilead's announcement of a royalty-free generic manufacturing licenses for 6 generic companies in advance of their filing with the FDA has the potential, the opportunity to be a place where we could save a number of years. So that's part of why the excitement is there. for sure. And the challenge is, of course, that it's still a very expensive drug in high-income countries, including the U.S., and ensuring access in the U.S. is also a reality that we're going to have to work on. But there's no question that this is a real advance and is hopefully going to save us several years.
Okay, right on time. Thank you so much, Chris. Please join me in giving our panelists a big round of applause. Just wanted to add that you'll find us here at Duke wanting to continue to host these kinds of conversations, bring in different partners, and we want to be able to be solution oriented as it relates to some of the challenges that we've talked about today. So please join us in that effort, and thank you again. I know we got a break now, Lisa, and we'll come back.